They have to just jump in to learn how to swim, right? If you don't get into the water, you're never going to learn. So when it comes to the clinical approach, they have to just start investigating. They have to start putting their hands on, and they have to feel many different feet types, so you just got to start touching, in my opinion.
David, Amanda, welcome to the podcast.
Thank you for having us.
Thank you. Excited.
So you will be presenting in Orlando at the AAOMPT Conference. So this is the prequel. This is the teaser. This is the movie trailer of what will be coming up when we get together in Florida. So my first hard-hitting question is, will you be presenting in Mickey Mouse ears? Are you going to be hitting Disney? That's the question everybody asks. Are you going to be hitting Disney beforehand? Amanda's already nodding.
Of course, yes, or at least a Disney costume, maybe of some sort. Maybe not Mickey ears, but Disney costume. Yeah,
do a little flavor. Yeah, I'm expecting that.
I do not have the ears, but I will be wearing the slippers.
That's all I'm looking for.
So,
all right, let's get down to business. What are you presenting on? What do people get to learn from you when you'll be together on stage at the AAOMPT Conference this October?
Yeah, so we're actually continuing off of a series of presentations that we've given at prior AAOMPT conferences. We've done the shank, if you will, and the tibialis posterior's roll on the hindfoot, midfoot last year, talking a little bit more specific of hindfoot and transverse tarsal joint. And then based on feedback, we're continuing down the midfoot to the medial and lateral columns.
So it's a sequel is what you're saying, which just fits with the Universal Studios and the whole Florida mindset. Yeah. That's great. All right. So let's dig into some specifics now that we understand where in the body we're located. Can you explain the importance of the interdependent relationship of motion among all the segments of the foot and ankle we'll say in functional weight bearing, because that's where we hope people are a lot of the time?
Yeah. That's a loaded question, and coming out with a knuckleball, right, to start off with. But so the interdependent relationship, I think, is best summarized in, the concept that we as physical therapists probably all know is the windlass mechanism. Great toe MTP extension, raising of the arch. Yes, it's by way of plantar fascia, hindfoot supination. But I think the outcome of that is perhaps even more important, and that puts the actual gastrocnemius and soleus on its best length tension relationship to produce force, to actually propel us forward. Adding to that, I think knowing that the foot is a load sharing system, so it's considered the longitudinal arch load sharing system, obviously just everything is related. And you have to have that internal rotation of the shank to have that proper supination, pronation of the hindfoot and the subsequent elevation and depression of the midfoot for our function and weight bearing. The biggest factor to that is really just what is the ground reaction forces doing and what can the muscles actually produce for force against that.
I mean, it seemed like you handled the knuckleball pretty well right off the bat. Okay. Moving on then, next pitch would be, there's a lot of segments in the foot. It might seem simple, but there's a lot of different parts, right? How do the different segments contribute to the overall function of the foot? If someone were to ask you that, let's say a new graduate PT, now they understand the basics, now they're moving on to a little more advanced concepts. How do those segments, or how would you explain those segments contributing to the overall function of that foot?
Yeah, great question. First question is how many? There's 10. If you really dive into the biomechanical descriptions, there's 10 segments of the actual hindfoot, midfoot, forefoot, even then the toes included to it. And yeah, they all are working interdependently. I think what's perhaps even more important than just that is understanding all of the muscles that actually contribute to it. I mean, we're talking 19 intrinsic, 12 extrinsic muscles, and we're trying to have a good understanding of how are each of those muscles controlling those segments.
All in a very small space as well.
Very much.
Does a lot to it. How about this one? Who wants to answer this? What role does the extrinsic musculature, you mentioned that a second, play in controlling the combined motion of the foot? That feels like a good continuation. We'll say foot and ankle because that also comes into play.
Mm-hmm. So as far as that... Yeah, I'll keep going. The extrinsics, that's part of my area of particular interest and what I'm trying to do a little bit of investigation on more specifically. But there is recent literature that's indicating that the extrinsic musculature actually supports the quote unquote arch height I argue that it's actually arch mobility more so than the actual intrinsic musculature. So having very good, activation, strength, endurance of those muscles is just vital.
All right. So we mentioned key kinetic principles a second ago, and I want to continue to play off this. Help us understand some of those key kinetic principles relevant to that foot and ankle segments that we just mentioned.
Yeah, kinetic as far as the motion goes, you can't have the proper pronation, supination of anywhere within the foot without having the appropriate motion at the shank, right? Internal, external. I think a good summary of the kinetics, the motion is, for the students that are listening in, when we do our basic goniometry of plantar flexion, dorsiflexion of the ankle, we know that there's a total range of approximately 70 degrees. However, in fact, there's really only about 45 to 47 degrees of that 70 that is really happening at the talocrural. The rest of it is actually occurring minimally at subtalar joint, but the majority is actually talonavicular and some also at calcaneocuboid as well. You could include the forefoot transverse metatarsal joint in there as well. Point being, there's approximately 35 to 37% of our plantar flexion, dorsiflexion that is not at the talocrural that we, as entry level, are taking our measurements at.
Understood. And I'm glad that was not on the MPTE, because that would be
right.
Mm-hmm. All right, let's get down to what I like about conferences when they go in terms of labs and techniques and hands-on and observations. Talk about some of those specific techniques or approaches that will be covered in the lab presentations to help enhance that clinical practice.
But I think just as what David described, we really go into taking that detail we talk about in how joints move and why it's important to look at multiple areas and break that down into the lab technique and look at very specific techniques that feel both quantity and quality of movement. And the way we've organized the lab sessions is there's time for active feedback from myself, David, Catherine Patla, who's our other colleague who's presenting with us, because I think a lot of individuals move too fast and too quick through end range and actually feel things are stiff when in actuality they're not, because they've blown through the end range and don't get to appreciate how the motion actually is. So we take that time to go back and forth and actually feel the motion together and provide feedback. And last time we were fortunate to have someone who had a problem in our session, and we could do an assessment, treat, reassess, and see tremendous improvements instantaneously with what we were doing. So we're hoping we can be lucky again this time too.
How was that? Trading in front of your colleagues, like no pressure there, right?
Yeah. Easy peasy. Yeah.
Right,
so that's actually what inspired this year's discussion, is that there was so much feedback requests that we could actually dive in further into our treatment approaches due to the success that we had seen in our session.
That's great. And how is it presenting with Dr. Patla? I mean, no pressure there as well. We're talking about pressure situations. That can be kind of fun with her on your team, right?
Yeah, no, it's awesome. And I think because we've both gone through the fellowship with Catherine for so many years and now we're colleagues, it's awesome to be on the stage with her.
It's got to be great.
Yeah.
All right. So let's talk about biases. I feel like that's a word that I don't know that I used it a ton before the last 3-5 years. What are some of the common biases clinicians might have in assessing foot and ankle function? We sort of alluded to one a second ago. And how can self-appraisal help identify these? Because we got to identify it before we can fix it or solve it. You got to know it's there.
Yeah. And you first have to admit that there even is a potential bias, right? And then you kind of walk through those steps. And so I think part of it is going back to one of our principles in that you must have normal joint function to have effective muscle function as well. And so we really
Say that again. Do it one more time.
You must have effective joint mobility, quantity, quality, in order to have proper muscle function.
Okay, good. Okay, keep going.
And so starting at that principle, we recognize the importance of looking at individual joint motion at the foot and ankle versus just gross osteokinematic assessment. I think that's the first bias, that when people look at a foot, it's this nebulous and it's too complicated. There are too many joints and it becomes sloppy in the assessment and the treatment. And then they get frustrated that no one's getting better, right? And so you have to break it down and go, okay, what do I know and what don't I know? And how can I get better at that? And the foot is one of those areas that I think can be particularly tricky if you don't understand the biomechanics well enough.
All right, so you'll be providing an opportunity, and that's sort of what an AAOMPT conference has, which is there's a lot of hands-on. If there wasn't, it would feel a little weird. But what's the best way you might suggest for clinicians to apply the hands-on practice from your presentation, from a conference, when they get home the next, we call it Monday morning applicable? Is there a suggestion like, hey, we want some carryover. We want to have the magic in the room, but then we want to be able to apply these things. We want to make them applicable. What would you suggest?
Yeah, I think ideally in the session, being able to go back and forth with one of us, like I feel, you feel, I feel, you feel, and we compare right then and there, and then doing it a couple times, right? This is a skill that you need to be using right away. But also what I like to do clinically is I do a functional assessment. Then I look at my osteokinematic, look at my joint mobility, treat, and go back and look at my function right away. So right then and there if something is working or not. And so I think that's a piece that people could take away day one is using that functional assessment, going and looking at the joint mobility, treat if there's a restriction, and go back and reassess. And if not, go back again and look again. So doing that continual assess, treat, reassess is a piece that I think is so critical.
Do you want to add something, David?
Yeah, and speaking clinically, I would say, they have to just jump in to learn how to swim, right? If you don't get into the water, you're never going to learn. So when it comes to the clinical approach, they have to just start investigating. They have to start putting their hands on, and they have to feel many different feet types. Going back to the bias, I think one bias is presuming that arch height is related to risk of injury, but that's inconclusive in the literature. Mobility is arguably more important, and they have to get their hands on different feet because there's different types of mobility for different sizes of feet related to different amounts of ground reaction force for specific demands of functional activity in sport. So you just got to start touching, in my opinion.
I now know what the promo will be for the episode. It'll be touch as many feet as possible from David.
Right.
Yes. And shoes off immediately when you first come in the room. That'll let air the puppies out a little bit.
Yeah.
But it also too, when we think about, I think especially at an AAOMPT level, we feel confident in our manual therapy skills, in our hands-on skills, our manipulation skills. But taking time in the clinic to work with your colleagues to get feedback on your techniques, and maybe spending a lunchtime on a Friday. Hey, let's run through some techniques and let's see if it feel the same as that I did at the conference that we had. Or let me show you some cool techniques. Let's talk through what we're doing. But taking time to hone your craft outside of the time with the patient.
That's smart. All right, so I'm gonna make you pick only one. What is each of your one key takeaway for clinicians that they'll be able to walk away from after your presentation? So this is the teaser before the teaser regarding your topic. What do you got, Amanda? What do you think people will be able to walk away with and be armed with?
Is that pun intended? Real quick. I was
literally trying to think of a foot pun and I couldn't before arm came out of my mouth. Yeah, you got it.
I think being more confident in their ability to assess specific joint motion. I think that's one thing we started last time, and we're going to be able to capitalize more on that this time.
All right, David, same question.
Yeah, I would say two things. I would say try to remain as objective as possible. And then number two is to ask for help, right? Seek, reaffirmation from your colleagues like Amanda had highlighted. And I think that also speaks to the self-appraisal component too.
Perfect. Looking forward to, I think October is a good time to head south. It's not too shabby to go to Orlando. So this is the prelude to one of many presentations going on at the AAOMPT Conference this October. For more information about the event, check out aompt.org. David, Amanda, looking forward to it. Thanks for the time sharing what you'll be presenting on this year.
Thank you, Jimmy.
Thank you for having us.